The unmet need that we continue to need to improve on is provide the most tolerable therapy with the most efficacious outcome for patients. And in 2020, the way we typically approach that is with standard targeted therapies. We do not typically use chemoimmunotherapy much, if at all, in chronic lymphocytic leukemia anymore. Not even only in the older patients, but even in the younger patients. The disease has clearly evolved to suggest that targeted therapies, such as in particular Bruton tyrosine kinase inhibitors or BCL2 inhibitors, have really set the stage in the landscape for the regimens and approaches that we use in the front line. We did 2 major studies in the recent past and actually presented them at the American Society of Hematology meeting in 2018 and showed that comparison to standard chemotherapy regimens, either fludarabine, Cytoxan, and Rituxan, FCR, or bendamustine and rituximab, the BTK inhibitor ibrutinib was superior for progression-free survival. And in younger patients, compared to FCR, it actually had an overall survival advantage as well. We had previous data that suggested that ibrutinib was better than other chemotherapy regimens such as chlorambucil and obinutuzumab, a very reasonable regimen in older patients. But again, ibrutinib had a significant improvement in the primary endpoint in those studies, and in particular in the Illuminate trial of progression-free survival. So because of that, we have now learned that really the frontline therapy is targeted agents over chemoimmunotherapy, either with a Bruton tyrosine kinase inhibitor, which I just mentioned, or with venetoclax, which I'll talk about a bit more in just a second. Let me say another word about BTK inhibitors. Certainly, ibrutinib is a standard of care in the front line. I just alluded to that compared to those randomized studies of FCR or BR. But we also know that a next generation BTK inhibitor is available, known as acalabrutinib. Acalabrutinib is another BTK inhibitor that's approved for patients with CLL in the front line as well as in the relapse setting. The Elevate trial we just reported on at the last ASH meeting in 2019 and showed that in this trial, which compared 3 different arms, either acalabrutinib by itself as a single agent, acalabrutinib with obinutuzumab, or compared to chlorambucil and obinutuzumab, that the acalabrutinib containing arms were significantly better compared to chlorambucil and obinutuzumab. So acalabrutinib has emerged also as another important standard of care using BTK inhibitors in the front line for CLL patients. And not just for high-risk patients. Certainly we know that if you have a deletion of the short arm of chromosome 17, a 17p deletion, or a TP53 mutation, which we should always be screening for as well, that clearly BTK inhibitors are the drug of choice in those patients, or perhaps venetoclax, but not chemoimmunotherapy. But it's not just those high-risk patients that should be getting these targeted agents. It's actually probably all patients, with maybe one exception. There are patients who are very, very favorable, who have what we call mutated immunoglobulin heavy chain variable region. They're IGHV mutated. I always like to say it's good to be a mutant. It means that these cells have undergone somatic hypermutation, and they're a more mature cell that leads to a more favorable prognosis. The unmutated patients are a bit more aggressive, and unfortunately, they're usually the vast majority of patients who present with CLL. Nonetheless, in the more favorable patients, the mutated patients, we do know that FCR, at least in younger patients who are fit and can tolerate that regimen, can provide a long-term survival benefit in roughly about half of patients. We have long-term data with a plateau on the curve out 14, 15 years suggesting that these people might be cured. The interesting thing is that we also showed in the recent ECOG trial comparing ibrutinib to FCR that in those favorable mutated patients, they do just as well, albeit the follow-up is relatively short, only on the order of a couple of years. We don't have that 14 or 15-year follow-up data, but that might be a patient population where we still want to consider chemoimmunotherapy. Otherwise, even in standard risk patients, patients who might have favorable cytogenetics, standard of care now has really evolved to targeted therapies, and we've discussed BTK inhibitors.